Thank you, Morgan.
See, I'm gonna go ahead and get my music off. Hey.
Thanks for that music. I'm so energized now. Hi, everyone. For those of you who are joining us for the first time, I would like to extend a warm welcome. I'm Malati Balasundaram. I'm a neonatologist and founder and co-chair of the FCC task force. It's great to see so many familiar names and faces. Thank you for joining, for taking the time to prioritize your busy schedule. And I just wanted to emphasize all the slides will be published on our website and fcctaskforce.org, and as well as shared in a follow-up email, which we encourage you to share widely with your colleagues and network. Next slide. Each of our webinar is dedicated to the NICU children of one of our speakers. Today, we have our very own Keira Sorrells, founder and executive director of the NICU Parent Network and co-chair of the Family Centered Care Task Force, and to her NICU children, Avery, Lily, and Zoe. Keira, thank you for sharing your family's NICU and post-NICU journey with us today. It takes courage to share such a personal story, and we deeply appreciate your willingness to be vulnerable. Your openness helps us all reflect, connect, and continue to improve the care we provide in the NICU. Next slide, Morgan. So we would like to share a few brief logistics before we begin. Please mute your microphone when you are not speaking and turn off your camera if you need to multitask. We ask that all questions and comments, whether spoken or in the chat, remain respectful, non-discriminatory, non-judgmental. Your cooperation helps us keep this space safe and welcoming for everyone. We also want to acknowledge that if you are a NICU parent who has experienced a loss, the first to talk may be emotionally triggering. If you need support, you are welcome to direct message us privately, and we will help connect you with the appropriate resources. Next slide. As a reminder, we follow the all-in meeting guidelines as created by our very own Jennifer Canvasser, NIC Society. For those of you who are attending for the first time, we use first names to address one another to break down the hierarchy that exists in healthcare and to empower everyone to contribute. Next slide. I would also like to acknowledge our webinar sponsor, Mead Johnson Nutrition, whose mission is protect, heal, and nurture in pursuit of a healthier world. Thank you, Mead Johnson, for sponsoring this webinar, and congratulations on 120 years of leadership in pediatric nutrition. Next slide. A warm welcome to our new organizational partners, Council of International Neonatal Nurses, Empowering NICU Parents, National Network of Neonatal Psychologists, Nebraska Perinatal Quality Improvement Collaborative, the NICU DAD, Sensory Beginnings. Next slide. With that addition, we are now partnered with 58 organizations. This work wouldn't be possible without our organizational partnerships. We appreciate relying on you all to share upcoming webinars, office hour session, newsletters, and are grateful for the opportunity to spread the word about your events and achievements as well. It's incredible to see so many family-led organizations alongside healthcare professionals organizations, and these partnerships is part of what makes the FCC task force special. Next slide. As we move on to the FCC task force leadership, I would like to acknowledge that our organization is led an equal partnership between healthcare professionals and family partners, which is one of our key strengths. Colby and I are practicing neonatologists, and Keira, Colby, and Morgan are former NICU parents. Next slide. Thank you to our family partners for your contribution to our work. I love that we are diverse in our infants' gestational age and diagnosis, that we represent birthing, non-birthing, and bereaved parents. Next slide. I would also like to thank our multidisciplinary healthcare partners for their time commitment and support for this cause. Next slide. I'm excited to share that we got over 2,800 members from 49 of 50 US states, except Wyoming. We heard there are no level 3 or 4 NICUs in Wyoming. So if you know of someone who cares for newborns in Wyoming, ask them to join us. And also we have 9 out of 10 Canadian provinces and for 76 countries around the world. Since our September webinar, we have welcomed almost 200 members. Next slide. So onto the committee's update. Carrie and Nicole continue to work on the present study toolkit creation, which will support NICUs in implementing unlimited parental presence, even in the face of respiratory pathogens like COVID-19. We are grateful to Angel Eye Health for their support of this work. Next slide. Jesse and Mia are creating a position paper to show our community where the Family-Centered Care Task Force stands on the importance of equity, diversity, inclusion, and belonging in the NICU. They plan to create a toolkit around ensuring silent signals in the NICU are consistent with FCC values and bring an EDIB lens to our work to ensure it's reflective of our commitment to health equity. Thank you to KSE Independent Educational Grant for their support for this toolkit. Next slide. And Daphna and Alex are busy sharing FCC task force related events, resources, advocacy opportunities, and education on our social media platforms. And Morgan is supporting them lately. Please take a moment to follow us. We invite you to tag us in our FCC related content so we can easily share and promote your FCC work. Next slide. Newsletter committee released its fall publication last month. It's worth repeating that units who share our newsletter with their colleagues and who print and post them in their staff spaces are reporting increased success obtaining buy-in around family-centered care practices. Next slide. We noticed in our research work that 59 out of 99 centers did not provide any trauma-informed care education. So, and we would love to focus on this topic in our work next year. So we are seeking your input. What's your practice? Share it with us. It takes less than a minute to complete the survey. Next slide. So if you haven't joined us for a free monthly office hours session, I invite you to do so. These are very informal opportunity to share your unit's barriers to implementing FCC practices in a safe space. 2 weeks ago, we talked about improving mom's milk use. Discussion were dynamic, and I learned something new every session. So join us. Next slide. We have presented 22 webinars so far, and with this being our 23rd, please utilize our webinar database located on our website under both the webinars and resources tab to view and share all past FCC Task Force webinars. We encourage you to share these widely with your colleagues and invite you to subscribe to our YouTube channel so you can be the first to know when we upload a new webinar recording. Next slide. We invite you to register for the 39th Annual Grievance Conference, Sensitive Issues in Sensational Times. While the date and location of this amazing event is changing, you can expect the same great topics, workshops, abstracts, and networking opportunities for those who work in the NICU space. Morgan will drop a link in the chat where you can register and learn more about abstract submission. With that update, we are moving on to our 2 excellent talks. It's my absolute pleasure to introduce Keira Sorrells, the founder and executive director of the NICU Parent Network, the only US-based collaborative of community-based NICU support organizations, representing 56 member organizations across 28 states. The network unites NICU parent leaders to amplify the voices of families and advocate for improved care and outcomes for those navigating neonatal intensive care and bereavement within the maternal infant health space. With that, Keira, please take it away.
Thank you, Malati. Well, like so many of you here today, I had premature babies. My triplets, Zoe, Avery, and Lily, were born at 25 weeks, 5 days gestation. And with Avery and Lily, they had a pretty uneventful, if you can say that about a NICU stay, a pretty uneventful NICU stay. It lasted 4 months. They came home together on the same day. And then Zoe kind of had a harder time, even from the very beginning, from their birth, in terms of how long it took them to get her stabilized, and just the procedures and surgeries that she had to deal with throughout her stay, which was 9.5 months. But at the time, which I'm glad I'll be able to actually talk about a little bit later as well, we were really fortunate that we were in a unit 18 years ago where it was possible for me to bring Avery and Lily with us when we were bedside, because that was 5.5 months of living an hour away from the hospital, where in order for me to spend time with Zoe, I had to bring Avery and Lily with me. So we had Mother's Day there. We had Father's Day. Um, we had a lot of playtime. We did some makeshift photo shoots that our primary nurse definitely loved to help us with. Um, but we of course couldn't wait for the day when Zoe would finally come home. But we did get to give them that time, 5.5 months of being together, and 5.5 months of us learning how to be a family of five. That picture actually was taken in the NICU. My sister is a professional wedding photographer, and she literally set up a mini photo studio when my girls were 8 months old, because one of the things that I had always dreamed of was having those beautiful newborn photos. And I couldn't have those, but she made it happen. And our NICU also just really gifted us with that opportunity to let me bring her and all her equipment into the unit. So we did finally get Zoe home, which was absolutely wonderful. The fun continued. They got to dress up for game day. We had play therapy together. Wrong picture. This picture is play therapy. That we would do together. They would practice eating together, which Zoe, who had a G tube, could have cared less about. But we had those meal times together. We had that playtime together. We got to pick a Christmas tree together. We did have their first birthday. We did more makeshift photo shoots together. We got the coveted 4-generation photo. And this was I just had to put this in here because I thought it was hilarious, which pretty much shows their personalities even to this day. And then on February 16th, 2008, when they were just over a year old, all of that changed because Zoe was gone. She died after a very sudden and unexpected rehospitalization. Her death was caused by a number of things, including MRSA, sepsis, flu, of course, all compounded by her extreme prematurity, her chronic lung disease, her lack of an immune system. It was just too much for her body to fight off, and she was gone within 24 hours of us walking through the doors of the ER. And all of a sudden, I had 2 children. I'll never forget that day that Zoe passed, and we had to walk back out to our car. I was pushing her stroller that I had brought her in with, but it was empty. It just held her oxygen tank that we didn't need anymore. But my life had to continue. I had 2 children, and they looked like twins. Because that's what you saw. You saw me with a stroller with 2 babies, 2 little girls that were the same age. And I remember even asking I was a part of this wonderful group of moms who had triplets and quads that were all born in the second half of 2006. And I remember after Zoe died, asking if I could still be in the group chat, because I wasn't sure that I still belonged. I had so strongly identified and been proud of this identity as a triplet mom of premature babies, but I didn't even know who I was now. We always got questions, of course, never malicious. No one's ever, intentionally trying to hurt us. But those questions it was like it just ripped the Band-Aid off and just opened the wound all over again. When they would say, "Oh, how fun, you have twins. Do you have any other children?" And in my experience, I did have these two living babies, so I could make the choice to answer, "Yes, I do. Their triplet sister is in heaven," or I would correct them and say, "Actually, they're surviving triplets." But for so many parents in the NICU who lose a twin, the loss is not evident. And those inadvertent comments, you can't stop them. And they can be very harmful. But I am so happy to have gotten to know Dr. Nicholas Embleton, who is here today to share his work with us, because he has found a way to at least mitigate a number of those comments. Sorry, I'm just trying to get my screens to cooperate. Dr. Nicholas Embleton is a consultant neonatal pediatrician and professor of neonatal medicine, Newcastle upon Tyne, UK, having completed pediatric and neonatal training in Newcastle upon Tyne, UK, and Vancouver, Canada. He helps lead a broad portfolio of research based in Newcastle that is focused in two areas: neonatal nutrition, including breastfeeding, and baby loss. Qualitative studies have explored the feelings and experiences of parents who suffered baby loss in a multiple pregnancy and the staff who care for them, which led to the creation of the Neonatal Butterfly Project. And this project focuses on the situation where one baby is lost in a multiple pregnancy, whether that's stillbirth, miscarriage, or neonatal death, and where at least one baby survives. In these projects, parents and healthcare professionals were interviewed and themes developed. They led to the development of clinical guidelines, training, and a film project. And I'm not going to say anything more because we want to hear from Nick. Thank you so much for being with us today.
Thank you, Keira, and thank you very much for sharing your presentation. I can't begin to imagine how hard it is for you and many of the other people on the call who've had babies on the NICU who've died. I have never had that experience, and I would never begin to imagine that I can know what that feels like. I'm going to try and keep to my 25-minute talk. Let's just hope I can share the right screens to get going. So let's see if this works. Okay. So I've got a couple of videos, and Morgan will try and play them because they're embedded and the sound doesn't work. So Morgan might try and play them from YouTube during the presentation. But as Keira said, I'm a neonatologist from Newcastle in the UK. And I'm going to tell you about this project that we've had running for more than 10 years now. And our project developed out of qualitative research with bereaved parents and staff, which included not only nurses and neonatologists, but also ultrasonographers and midwives. And we talk about co-twin baby loss, recognizing that the use of the word twin doesn't acknowledge the situation that Keira was in and many other parents were in. But people often talk about lone twins or twinless twins, so that's why it's been here. And this includes the loss of a baby from a multiple pregnancy, either as a miscarriage, stillbirth, or neonatal death. And as you can understand from Keira, this is a hugely emotional and upsetting topic. And I know some of you will be very upset by the issues raised. So, feel free to log off if that's what you want. So we did research, we co-produced guidelines with parents, we had a film project, we're doing some follow-up research, and I'm going to kind of briefly share all of this with you. When I first came to this area, we were thinking mainly about kind of practical aspects of good practice, communication and empathy. Of course, we were aware of the ethical aspects, and I guess as a sort of physician interested in biology and illness, that's kind of where my understanding kind of stopped. But as I kind of looked more into this area, I realized that there were very many other areas, and the NICU just sits within society. And all of us are sharing our professional lives with the personal lives of these families, the journeys that they're on. We make friends on the neonatal unit, we might make friends with some of the parents. And all of this impacts on our professional identity. And for me, this was really kind of quite a mind-blowing experience. I never sort of intended to get involved in this area of research. I mean, my area of research was nutrition and protein and amino acids, and I found myself increasingly interested in how we better understand this. And I often say to people, I'm not a touchy-feely physician at all. And I've surprised myself at how interested and how important I recognize feelings are within all of this. And this isn't something that you really ever get talked about in med school. And when we spoke to parents, we were speaking to bereaved parents who were involved in an active decision to limit further intensive care. And it was during these conversations that we realized that some of the parents we were speaking to were parents of twins or triplets where one had died. And throughout my neonatal career, which goes back to the early 1990s, I'd always recognized that we cared for babies on the unit who had a brother or sister who died, and we simply didn't know how to address it. And often I think we just tried to ignore it because we felt a bit uncomfortable. So we were speaking to parents, and I came to realize this little phrase, it's the little things that count, that parents look for these touches of humanity in a technical world, and all of them will remember how we made them feel decades later. And many of us will recognize the unique bond that we form with some of these parents, and the parents form with us, because sometimes we may be some of the few people in the world who ever knew their baby. And I learned that parents don't expect us as NICU staff to be counselors or miracle workers, but they do expect that we genuinely care. So we focused in on this issue where one of a multiple pregnancy baby dies and one survives. And as a society, I think we're generally fascinated by multiples and twins, how similar or different might they be. And there are many kind of celebrity twins, twins in film. And of course, as always, you know, twinning rates are increasing worldwide due to a whole variety of factors. But I don't think many people stop to think what life might be like if one of the twin or triplet pregnancy don't survive. This is a kind of film documentary available on Netflix, which is very, very moving, but very powerful. These are three boys who were deliberately separated at birth in what all of us, I think, would consider a cruel psychological experiment, because they were placed with three families from different socioeconomic strata, and they spent their entire childhood not knowing that they had a brother. And then at the age of 18, two of them bumped into each other, and then they found the third one. And for a short period of time, they became media celebrities. But soon the stress of knowing that they'd been deprived of a childhood together really created problems for all of them. And very sadly, one of them committed suicide in his 30s. And this is just a screenshot from an American daytime talk show where these two girls who were adopted independently by parents who thought they were singletons were brought together on live TV. And again, I think most of us would feel this is also unethical. I mean, how dare we expose children to this level of emotion? But I think you can see how challenging this area will be. So twins and multiples are seen as special. We're fascinated and we're moved by their stories. Many of you may not know that Elvis Presley was actually a twin. His brother was stillborn half an hour before him. Elvis was often caught at the grave of his brother. And his mother talked about how his search to make a connection with his brother who died defined his life and career and motivated him in many ways to be the person that he was. But of course, if we walk down the street, we've no idea whether these people we're bumping into might be twins. We're also we also have no way of knowing whether anybody that we bump into might be a twinless twin. And as Keira pointed out, I mean, if you have a triplet pregnancy and one of your babies died, but you walk down the street with two babies, people automatically will assume that these are twins. And loss of a baby from multiple pregnancy might happen for lots of different reasons and different stages. It may be associated with assisted reproductive techniques or terminations for medical reasons, maybe an unexpected stillbirth, or it might be the co-twin death on the neonatal unit. And we were interested in how parents coped. How did our behaviors as health professionals help or hinder? And how can we best make a difference? And just think about these different scenarios. The sonographer who scans a twin pregnancy but only hears one heartbeat. What must it feel like when parents come in having lost one of a twin or triplet pair to find their baby still sick? What about us as doctors or nurses caring for somebody? How does it feel to care for a baby when nobody told you that they had a brother or sister? And then what does it feel like to come back onto the neonatal unit where you used to visit two of your babies and now there's only one there? And all of the feelings that arise when parents then have to go home and break those social ties. And then all of the kind of anxieties and uncertainties that parents might experience around how they tell the surviving sibling or other siblings in the family that they had a baby brother or sister who died. And just imagine walking in somebody else's shoes. What does it feel like to return to an antenatal clinic after an in utero death? Or be put on a postnatal ward with other sets of twins, return to that same room on the neonatal unit where your other baby died, or come to follow-up clinic when nobody says anything about the baby who died. And then when you yourself walk down the street and you see other twins in a pushchair, how does that make you feel? And then on every birthday, every anniversary, every first day at school, what do you think about how life would have been if your baby had survived? So I want to encourage all of you as health professionals that you all have enormous power and that your behaviors and actions affect families for the rest of their lives. And in our research, we did a standard thematic analysis and we came up with these 8 themes. There were many more, of course, but we wanted to come up with 8 themes that we could kind of translate into guidelines that might make a difference. And I'll very briefly kind of go through these in the presentation, but importantly, recognizing the importance of twin status or triplet status, acknowledging the bereavement, supporting the parents emotionally, and providing appropriate information. Aspects of continuity, so us handing over what we know about the family and what happened. Some aspects of memory making, logistics around cot occupancy and discharge. And of course, there are many more themes, but I can only go through these very briefly today. But I think if you want to take away one word to remember, this is all about acknowledgement and acknowledging that this was a twin or triplet pregnancy, acknowledging that there was a baby who died, acknowledging that parents are going to face a different set of challenges. So acknowledgement really is at the key here. So Morgan, shall I just stop screening? Then we can just see if you can share that YouTube video.
Yes. And would you like me to start with the first here? What
Yeah,
is the
just do
butter-
the first one. Yeah.
Great.
Baby Matthew is quite comfortable as he begins to appreciate his place as the youngest member of the Watton family. But what he isn't aware of, at least not yet, is the story of his birth and its legacy. The Wattons were actually expecting a twin birth.
I think for me initially I was terrified. It was a bit of a shock.
But then pretty quickly, you know, you settle and actually come to the idea that twins are actually quite cool, could be quite fun.
Since the 1970s, the number of twin or multiple births in the UK has increased steadily.
Shocked, because at first it was only 2 heartbeats that they'd seen, and then we went back a week later and then there was 3.
The sonographer scanned us, she didn't say a thing, so we just assumed the baby had died. Then she started scanning me again and said, I'm happy to let you know that we've found a heartbeat. In fact, we've found 2. And I just burst out crying even more and just went, it's all your fault.
In 2015, 16 out of every 1,000 birthing mothers delivered infants in multiples.
A lot of our babies are twins or triplets, and I think it's probably true that always in the unit we'll have more than one set of multiple babies.
Prematurity is common amongst these multiple births, but more so, sadly, so is the risk of death.
That baby that was in the incubator there was nothing like that baby we'd seen in high dependency. She'd swollen up, the only thing I can think, like a puff of fish.
When he died on the Friday in my arms, well, on my chest, the doctors came round and said that he'd got 3 infections.
I would think that at any one time on the neonatal unit, we're likely to be caring for at least one baby who was from a multiple pregnancy where one of the other babies died. So it's probably a very common occurrence on most neonatal units throughout the UK and probably throughout the world. The shocked parents are caught between joy at the birth of their child and grief over the loss of the other baby or babies.
Straight away we knew that we had to do the best we could for him, because sadly Beth was gone, whatever we did now.
I was angry, I was numb, I was hurting.
We were both in shock.
But I had to stay strong for him.
And to make matters worse, doctors and nurses often have limited training in expressing emotion and empathy.
A consultant who didn't perhaps know I could hear reprimanded very sternly the registrar for calling him out several times while he was trying to have his tea on a weekend for a baby that wasn't going to live and would be dead by the end of the weekend. And I heard that.
The fact that a surviving baby like Matthew has a twin sister who has passed away may easily be forgotten by hospital staff. And this can cause long-lasting trauma.
I remember very vividly on the whiteboard next to his incubator were the words twin 2, somebody going, oh, well, you don't need that, and wiping it out. So it's almost like, well, we're going to start fresh now. We've got a single baby.
I did hear, unfortunately, of a few cases of conflict between staff and parents. Some pretty explosive episodes where there'd been lots of yelling and screaming.
Over the years, we have conducted in-depth research on what families experience and how we could help them better.
We interviewed parents and we interviewed health professionals, and it became clear in those interviews that health professionals were struggling with the emotional side of dealing with caring with these babies. They were, as you would expect, very confident with the medical care, but it was the emotional side. So from that, we were able to get further funding to develop some guidelines to support health professionals.
And this is what we came up with, the Butterfly Project. A project that at times confirms simple truths that were blindingly obvious, but never fully appreciated. The Butterfly Project provides us with a simple way for us as healthcare staff to recognise a surviving twin and address issues to help these families.
I think what health professionals perhaps need to take on board is that parents who have lost a multiple and are on the ward for several months actually become quite medicalised. They're sitting there, they're watching their baby every day. And actually, nurses can learn from parents.
It's very easy as a doctor just to put your foot in it. And you might just never know that that baby had a brother or sister who died. So I think it just gives us that bit of warning, and then it provides this sort of continual sort of memory to keep on recognising that what that family are dealing with are just a bit different from lots of the other families.
In the hearts of those who loved you, you will always be there.
There you go, son. Oh, nice and fresh. And Daddy will come up next week and cut your grass.
We want baby Matthew and his family to realise that for us, he is still a twin.
So I'm just going to quickly go through some of the themes. As I say, very important for us to hand over and recognize the pregnancy as a multiple pregnancy, if that's what parents would like us to do. And many parents told us that people just didn't seem to know, or they just forgot that this baby was a surviving baby from multiple pregnancy. And it was actually a mother in one of our feedback groups who came up with the idea of using a butterfly cot card. And as I say, that afternoon I thought, well, that's just brilliant. And we went back and we created the cot card, and the nurses laminated it, and we offered it to parents, and we've been using it ever since. We just printed it out ourselves to start off with. And as soon as we did this, of course, it identified more than one baby on the unit as being a surviving baby from multiple pregnancy. And these two babies here, these two families became quite close, and they're still in contact with each other now. One of the doctors at the time really quite upset me, and she often said to me, "At least you've still got one." That was one of the worst things that anybody could possibly say. Before you tell a grieving parent to be grateful for the children they have, just think about which one of yours you could live without. Providing emotional support was very important to families, and many of the families kind of talked about the importance, and I've come to recognize the importance of naming babies. And so this is why we offer parents the opportunity to write the name of the baby who died on the cot card, and then all of us can remember, because on more than one occasion I would get the names mixed up and I would use the name of the baby who died. Continuity, of course, is very important. And whilst parents want opportunities to be able to talk about what happened to them, they don't expect that they have to retell us the story. We should know as healthcare professionals the details of the pregnancy and what happened. And we should hand over between us that kind of information. But parents still want an opportunity to talk about it. And as I say, the importance of naming is also very important here. Memory making is a massive topic, and I'm not going to go into it in any detail, simply to say that parents really value shared memories. So these may be photos where you have all the babies together in some way, shared blankets, shared toys. So anything physical that the parents can use and see where both the twins or triplets are all together. Co-occupancy is a major issue. We struggle with knowing what to do when you had twins and one twin died, because you know that within 12 hours another baby is going to be admitted onto that neonatal unit, into that space, and the parents of that new baby will have no idea about what has happened. So what we do now is we explain to parents of a twin baby, if they die, one of them dies, that we will be admitting another baby in the next 12, 24 hours. And we now ask them what they would like to do and whether they would like to be moved to a different room or a different space on the unit. And actually most of the parents now ask us to move the surviving baby into the cot space that was occupied by the baby who died, perhaps in some way to protect that memory a bit longer. And then just to kind of touch on the idea that going home is hugely challenging. I mean, as neonatologists, we think, well, this is great. This is kind of like the end of their neonatal journey, but it just opens up a whole set of other challenges and issues for these parents when they get home. So all of us should recognize the lifelong impact we have. As I say, more than 30 years later, parents remember how we made them feel. And as I say, just recognizing that small things can make a big difference. So this project's very much more than just putting a butterfly symbol on the cot. It's about how we speak to parents, the words we use, our behaviors and body language, and how we interact with them. And around the same time I was developing this, I got connected with Millie, who you can see here, whose baby Sky died at a day of age from anencephaly, sorry. And she's taken it on as a charity. She's helped us to develop information leaflets and guidelines and share these around the world, and also translate all of our tools. And she has a website that is now starting off in the US as well. So you can go to the US website for Sky High and link into her through that as well. But I was very much struck by the power of hearing parents speak, and that's what led us to making these films that I showed you there. We collated these on a website, so you can view many more of these films on the neonatalbutterflyproject.org website, along with tips and advice, both for health professionals, but also for families and friends. And we then went on and created a 4-hour online learning course, widely supported by lots of advocacy organizations, that is free to access, but if you want to get a certificate, you have to pay a small enrollment fee. And again, I can provide links and details to that with the FCC committee. And these courses are made up of short 5-minute steps, which might be audios or small articles to read. And so you do a few short steps each week over a 4-week period. And that's been very successful and widely accessed. I mean, I think we've had almost 3,000 people from more than 100 countries around the world. And the feedback that we've got from that course has been very positive indeed. And the butterfly symbol has worked very well for many families, not all families. Clearly, this symbolization won't work for every family in every kind of culture and context. But for most of our families, it seems to work well. We developed these little badges, and so this is Erin taking the butterfly that represents her sister Ellie Mae on her bag to school, because they very much, as I say, liked the concept of the butterfly. And of course, in doing all of the research and developing the projects, I'm indebted to all the parents who were able to share their very emotional and difficult experiences with us. So as I say, this is more than just a kind of cop card. It's encouraging us to think about behaviours and actions and recognise that quite often on the neonatal unit, it's the little things that count, and all of us here today should remember that we have power to act as a leader. And I just want to very quickly finish off with some research that we started last year. We had over 200 families respond to our survey, because I was very interested in knowing how families like Keira's family make sense of what happened. I mean, how do they remember the baby who died? Do they have special remembrance days? What do they say when someone asks you, how many children do you have? What do you do on anniversaries and birthdays? And how do you feel triggered, perhaps, when you see other twins or triplets? So I was going to read you out some very quick quotes. I'm a lone twin. My identical twin died at 5 days of age, and I've always felt that there was some part of my life missing. Being a lone twin affected me growing up. I never felt like I fitted in anywhere. I've always had a feeling of loneliness which I can't explain. When did you tell your other children? My survivor has always known that she's a twin, and we've talked about this in different ways as she and our older brother grew up. However, I've still been unable to tell them that I had a termination for medical reasons for Susan, just that their sister died in the womb. Now they're grown up, I wish I'd told them before, because now it feels like a huge deal. How many children do you have? If it's someone I'm going to have a long conversation with, or someone I will see again, i.e. not a complete stranger, then I say that I have 2 children, but that Kai is a twin and that his brother died aged 12 hours of age from a heart defect. But if it's only a fleeting conversation with a stranger, I don't mention it, but then I do feel guilty afterwards. I feel as though no one mentions it or asks, so I feel awkward bringing it up. I just want it to be acknowledged. I feel like no one else remembers my lost baby, or how sad it is that she's not here alongside my survivor. Feels like an exciting club that I never quite got access to. I never got the opportunity to feel like a twin mum, and it seems such a special thing that I missed out on. And it makes me feel sad for Kai that he will never know that bond. So we're working through all of our data with Ella, who's the RA who's leading on this. And I've got a short film clip, but perhaps I can show that later in the session if we have time, with some families that we've made videos with. So I'm just going to wrap up here so that we can keep the time. As I say, acknowledgement really is key, and I want to encourage all of you as health professionals that you have the power to really make a lasting difference to families' life. And I want to acknowledge the many amazing parents that I've worked with, and all the parents in your organisation present here today. And then just a quick plug for these 3 courses that you can see here. So on the left is the course based on the Butterfly Project, Loss of a Baby and a Multiple Pregnancy. But we also have a course that deals with lactation after loss and the choices that parents might want to make. And we've recently finished a course on managing uncertainty in perinatal medicine and palliative care. And I hope that I can collaborate with the FCC task force next year and look at how we maybe adapt and introduce some of these materials to you in North America. So I'm going to finish there. It was a bit of a whistle-stop tour, but happy to take any questions or have discussions afterwards. So thank you very much indeed.
Thank you, Nick, so much. And I just, when you really highlighted the acknowledgement, I mean, that was really all I was ever looking for as well, especially in those early years. Now it's very personal for me now, and I don't seek it as much as I did before, but I really appreciate that highlight. And we have many requests for links to the courses, lots of people interested in that. And we do have a couple of questions as well. From Liz, would you encourage sharing with families what the butterfly card means? Some traumatic events can happen from families meeting families as they share space in the NICU. Professionals in the US often feel they can't share anything because of HIPAA. So how do you handle that?
Yeah, I mean, we obviously tell parents that if we put a butterfly card on their incubator, other parents might come up and ask, well, what's that about? And are you prepared to answer those questions? And so, of course, parents have to be aware that that might happen. It does create challenges after discharge because they will take the butterfly on their health records. They will go to their local family doctor, and the family doctor has no idea what this butterfly is. They go, oh, that's a pretty butterfly, not knowing that it represents the death. So it does, of course, create other challenges. It's really difficult knowing what do we say to other parents about this. I witnessed many traumatized parents whose babies survived on the unit, but they had to watch other parents' babies die. You come in one day and little Jimmy's not there anymore. I mean, that's just awful. And I've never really known how to do that. But I have said to parents of babies who've died, would you like me to tell, the parents of the other baby in the room or whatever? Do you want me just to tell them what's happened? Or do you want me to tell them that your baby's, going to die in the next day? Because I don't know what parents want. So I think it's just about being open and honest. I don't know what works. Everybody wants something different. But if you don't tell parents what's possible, then we're never going to get it right. So we have to just try and have this discussion, however uncomfortable it is. But you're right, we can't go around telling people without permission from parents. But most of the time I find parents say, well, look, yeah, that sounds great. Please just tell them what the butterfly means.
Yeah, I think that's really important. Just kind of giving that autonomy back to the parents as well, because we're in a time where we don't know what to do. We don't know what may be coming our way. I certainly wasn't prepared for the questions that I would get. So that kind of anticipatory guidance is really, really important. And you actually mentioned something about taking the butterfly on to the pediatrician, and that was another question was, can this be communicated? Is it communicated? Can it become a part of the electronic health record?
I mean, the butterfly is a beautiful symbol, but it's used in lots of other contexts. I know hospitals where they've used the butterfly symbol to represent somebody with Alzheimer's. I mean, this is always going to be challenging. I mean, it works great on the neonatal unit because you have a fixed pool of staff and you tell everybody what it means, and we can all know that. But there's like 200 pediatricians when my baby goes home. I mean, can I educate 200 of them? It is very difficult. So I think really what we have to do is just prepare parents for the fact that they're going to bump into health professionals who won't have a clue what the butterfly represents and may not know that they had a baby brother or sister who died. And how are they going to deal with it and how are they going to prepare themselves for it? In the same way, how do you prepare yourself to meet your friends after you've had a twin pregnancy and one baby died and think, oh, you've had twins, how lovely. How are you going to deal with that? So I think what we would say is we try and help parents think through how they might deal with it, but we can't stop these problems happening, I think.
Right, sure. And what about parents who maybe aren't ready to acknowledge that the twin has died and really want to focus on the surviving twin?
Yeah, absolutely. I mean, we've always, of course, we would never put a butterfly up without asking parents. I mean, that's the whole point. We have the conversation. I have to say, I've only ever had one parent who said they didn't want the butterfly card. It was a triplet pregnancy, and one of the triplets died at about 10, 12 weeks. And the mum said, look, in my head, I think I have twins, and that's what I want to do. And that's fine. So it is just about individualizing it. As I say, we can't second guess what parents want. And if we start second guessing, we're going to get it wrong. So we just have to have these conversations.
we've got time for about one more question. One from Bob. Oh, is there anything specifically you do for the medical staff who will care for a surviving multiple after discharge so they will appropriately acknowledge the baby who has died? I would imagine that follow-up provider often can say the wrong things or nothing.
Yeah, I mean, we try and educate, we try and teach all of our residents and fellows and other attendings what it all means. In the UK, we do have handheld child health records that the parents will take to vaccination clinics. And so we do have, or Sky High developed some stickers that put on the front saying, I had a brother who died, his name was Rami, or whatever like that, it's another way of getting the message. But yeah, I mean, communication in healthcare is hugely challenging, and trying to communicate these messages is very challenging. And I imagine that many of us who are health professionals over the years have cared for a baby without ever knowing that they were a twin, and it's awful. You feel like you failed, but yeah, we just have to have these conversations.
Yeah, absolutely. Well, thank you so much, Dr. Embleton, for being with us today, for your work in this area. It's so important. And yeah, we look forward to collaborating further. And actually, we do have the Sky High Foundation is a new member of NICU Parent Network. So we're very grateful to be able to partner with them and help spread the word of their work. So thank you so much.
Thank you.
All right, thank you both so much for that very touching talk, Keira and Dr. Nick. I'm going to go ahead and introduce our next speaker, Dr. Deborah Buehler, and I'm only going to give a short version of her bio, and I'll put the rest in the chat so that we can be sure to have extra time for question and answer at the end of her talk. Deborah Buehler, PhD, is an assistant professor in the Department of California, San Francisco. She is the director and master NIDCAP APIB trainer of the West Coast NIDCAP and APIB Training Center at UCSF. Deborah was a founding member of the NIDCAP Federation International Board of Directors and currently serves on the board as its president. All right, Deborah, with that, I will let you take it away.
Thank you, Morgan. I am just so incredibly moved from the Butterfly Project's presentation, and I just wanted to thank Dr. Embleton and Keira for that lovely presentation. And acknowledging and individualizing and drawing from the infant's voice is that was such a powerful message. So I just wanted to really thank you for that. And it fits, I believe, with my presentation. Can you see my slide? Is that good?
Yes.
Okay, so, oh, good.
Yes.
So my presentation is the Newborn Individualized Developmental Care and Assessment Program, or NIDCAP, and it's all about nurturing and being nurtured. I'm going to advance. Okay. So every family with a new baby begins with a unique journey. Here are two very different ones.
Where am I?
This is one family's beginning. They had the optimal wished-for pregnancy and newborn experience. Meet Mila and her parents, MJ and Lucas. Mila spent 9 months developing in her mother's healthy, safe womb. In utero, she was protected, received optimal nutrition, motor system flexion supports, and maternal day-night cycling, and hormonal entrainments, and so much more. This exquisitely attuned mother incubator is thought to evolve to ensure continuity of the species. And Mila and MJ's relationship with her baby was beginning to joyfully unfold even before Mila was born. Over her 40-week gestation, Mila's brain grew at a tremendous pace alongside the formation of her essential organs and systems. At the time of her birth, Mila, a healthy newborn, was prepared to breathe, maintain her heart rate, tuck, grasp, move smoothly, and to sleep soundly, cry lustily, and to begin to alert in her interactions with her mother and her father. From birth, Mila moved into the arms of her parents for protection and nurturance and care. And over the years, Mila continues to move out into the world and develop with ever more independence, curiosity, and determination. Evolutionarily, human infants are described as promised 3 environments: the mother's womb and all that includes, the mother's breast and parents' bodies, providing physical closeness, especially with skin-to-skin holding and breastfeeding and all of their enormous benefits, and the species social group, increasingly with family members in the larger community. This was Mila, MJ, and Lucas's experience, and this is how our human species have adapted to optimally develop. Here's a very different beginning for a family. This is baby Amelia and her parents, Mandy and John. Amelia's birth at 25 weeks, 6 days was unexpected. Neither Mandy, John, nor Amelia were prepared for the pregnancy to have been cut short. In Mandy's words, "Grief overwhelmed me. I had lost my pregnancy, my birth, my hopes for the future, and I had nearly lost my life." The following are going to be powerful excerpts from blog posts that Mandy wrote, and this first one is on the numerous barriers she faced, shedding light on the challenges within the healthcare system. She wrote, "For 3 months, I traveled 90 minutes each way to spend 12 to 14 hours sitting at my daughter's incubator. The NICU can be the loneliest and most disempowering place for parents. Having to request permission to enter the NICU, abiding by the visiting time rules, having to ask staff for their permission to hold your baby, and feeling in the way as staff go about their daily duties, only serves to chip away at the rapidly disintegrating mental and emotional health of parents. Every single element of parenthood, as it ought to be, is turned on its head, and in many instances, the parents that remain are mere shells of their former selves." Day after day, I got to know my daughter as best I could by observing her across the divide of the incubator. At times, I would reach inside the incubator and attempt to calm her, but these episodes never lasted very long, and Amelia would often reject my approach, something that compounded the rapidly increasing feeling of failure. As nobody else seemed concerned, I felt that her caregivers knew best, and I never raised my concerns. I was struggling with the void that was developing inside of me, the one that longed to feel a part of my daughter's life, to be able to nurture her. We soon discovered that despite spending 12 to 14 hours each day at our daughter's cot side, we didn't know her at all. So what Mandy and other parents discover is a great deal about the field of neonatology. They become familiar with medical technology, they learn how to interpret various equipment and understand the hospital's protocols. However, it can be challenging for them to truly grasp who their baby is, and that there is no piece of equipment that can provide insights into the uniqueness of their child, nor how to nurture them. Mandy went on to describe Amelia's tremendously difficult medical course and her own realizations over time. She wrote, "Amelia's NICU stay was marked by several resuscitation episodes, many infections that brought her to the brink of death. 4 weeks on a ventilator, 7 weeks on CPAP, several unsuccessful attempts to commence feeds, 8 blood transfusions, and lung suctioning every few hours, which broke my heart to observe. But the instant I began to understand that as a parent, I could make a valuable contribution to her care in a way that no healthcare provider could, gave me the impetus to stay positive and to adopt the mantle as her advocate. It would take me another 3 years of reading and researching to join the dots and come to the realization that many of my daughter's issues might have been prevented had I been more knowledgeable about NIDCAP and had it been available in our NICU. So every year, 10% of infants are born prematurely. Mortality rates are steadily declining. Nonetheless, studies indicate that more than 50% of these premature infants experience poor health outcomes, learning disabilities, attention deficits, motor challenges, behavioral issues, and or difficulties in school, and perhaps throughout their lives. Many families with infants who are born prematurely may see themselves in Mandy, John, and Amelia's story. They experience grief over the loss of the full 9-month pregnancy, face barriers that separate them from their infant, and feel at the mercy of medical professionals and the hospital system. This often leads to a sense of powerlessness and inadequacy. Central to this struggle are the fears surrounding the lifelong effects of prematurity on both the infant and the entire family. These challenges are frequently exacerbated by systems that fail to recognize, value, or support infants and families. The Newborn Individualized Developmental Care and Assessment Program, or NIDCAP, was developed to address these often painful, traumatic experiences of stress, isolation, and medical and developmental challenges faced by newborns and infants and their and their families in hospitals all around the world. By focusing on strengths and strivings, NIDCAP's nurturing individualized care supports infant and family experiences and outcomes and healthcare teams and their care. The NIDCAP approach is founded on the synactive model, which were both developed by Heidi Zahls, or Heidi. The synactive model views human development as an ongoing process that's always influenced by the environment. For fetuses and newborns, the expectation of first being in the womb and then in their parents' arms stands in stark contrast to the experience of preterm infants. Their experience with warming tables, incubators, machines, tubes, wires, accompanied by gravity, coldness, bright lights, loud sounds, hectic activity, and unfortunately, pain. The ideal of a healthy pregnancy culminating with the infant being held by their parents contrasts sharply with the reality of the early delivery with separation from their infants who require complex medical care provided by others. NIDCAP aims to tailor caregiving practices and hospital environments to mitigate this mismatch of the displaced fetus and premature parents. From birth, skin-to-skin holding and other adaptations to caregiving nurture survival, healthy development, relationships, and well-being. The key to reducing mismatches in the environment and the infant's expectation and readiness lie in understanding each infant. So their current level of functioning and their goals. And the way to access this understanding is through observations of their behaviors. So Heidi viewed behavior as an ongoing expression of the baby's brain organizations and their neurodevelopmental agenda. She understood that interactions between infants and the things they experience influence outcome. The positive ones positively and the difficult, stressful ones negatively. Here is an explanation of understanding how observing behavior works with the NIDCAP framework. This developmental model applies to human beings of all ages, but then the description I'll give now focuses on infants. NIDCAP is based on readily observable behaviors. Behaviors are continuously developing in interactions with one another and the environment, and they can be described as in 4 groupings or subsystems: autonomic, motor, state, and the attentional interactive one. Everything the baby does can be described in terms of these systems, and here is an overview of them. At the behavioral core of the infant, the first to develop is the autonomic subsystem, with breathing, color, and visceral signals such as spitting, gagging, and hiccuping. From these images, the first baby is showing some redness and likely some irregular breathing, and the second one is showing some paleness, duskiness, and maybe pausing in his breathing. These are observable autonomic behaviors that give the caregiver information about the infant's relative stability. The next layer to develop is the motor system, which looks at tone, posture, and movement. These babies are showing 3 contrasting motor stabilities. The first baby shows extended limpness. The second baby is moving into extension with her arms and fingers. And the third baby is showing soft, relaxed, tucked arms and body with her fist resting softly on her mouth. The motor and autonomic subsystems may interact with one another, so challenges in one system may lead to difficulties in the other. For instance, breathing pauses from the autonomic system may lead to limpness in the motor system. And conversely, these subsystems may work to support one another, so behaviors such as tucking and grasping from the motor system may promote more regular breathing and stable color from the autonomic system. The third subsystem to develop describes observable states, which are based on the Brazelton Neonatal Behavioral Assessment Scale, and they include deep sleep, light sleep, drowsy, quiet awake, and/or alertness, arousal, and upset. And there's a lot of information that can be learned by observing baby states, including range, robustness, and variability or transitions between them. So infants from these images show sleep, alertness, and upset. The state subsystem also interacts with the autonomic and motor systems with rippling effects in all directions. For example, Regular breathing and relaxed flexions may support restful sleep or perhaps eye-opening. Panicked, wide-eyed alertness or fussiness may lead to extended movements or postures and very rapid breathing or even pauses. Within the state subsystem is the attentional interactive subsystem, and this system becomes increasingly robust, organized, and available over time. So as with the other subsystems, the attentional interactive subsystem interacts with the others and may hinder or support attention. So the first infant in this image shows a low-key strained type of alertness compared with the second one's robust active engagement with her world. This set of images includes a wide range of infant subsystem functioning. Each photograph reflects the stability of the infant at that moment. You can see infants exhibiting well-organized behaviors, as well as ones who show disorganized behaviors as they engage with or perhaps are overwhelmed by their environments. So understanding infants' relative stability and recognizing their goals, such as maintaining steady breathing, tucking, grasping, sleeping restfully, or awakening robustly within their extrauterine environment is critical. By adapting caregiving and physical environments to support their strengths and efforts, we create opportunities that promote stability, health, and development. Heidi developed a tool to understand each infant and their experiences within their environments, the NIDCAP observation. And here is an example. So Henry was an infant in the NICU who was carefully observed by a professional trained in NIDCAP observations. This page represents 10 minutes from a comprehensive 60-minute observation. And in 2-minute increments, the observer noted Henry's breathing patterns, heart rate changes, movements, and states of sleep, wakefulness, and more before, during, and after his direct care. This information was used as a guide to summarize Henry's experience. So this is an excerpt from Henry's NIDCAP report. Note how each one of Henry's subsystems was observed in their interaction with one another and with his caregiving experience. So the report had written, had included, over a period of 9 minutes, Henry received 18 milliliters of milk. As the feeding progressed, he became increasingly restless and made several attempts to bring his hands to his mouth. His thumb was brought near his mouth and eventually succeeded on sucking on his fingers, which seemed to help him settle his heart rate back to around 160 beats per minute. However, during the feeding, Henry gagged and grimaced. He drew back his upper lip, seemingly indicated that the milk tasted unpleasant to him. This detailed observation of Henry's subsystem environment interactions led to understandings of what aspects of the physical and social caregiving environment were working for him and what aspects he would profit from additional support. So from his neurobehavioral goals, he showed that he was working towards steady breathing, tucking himself together and using his hands and feet, and longer moments of quiet wakefulness. This information was used to make recommendations for support. So when caregivers understand strengths, sensitivities, and strivings, care can be individualized to meet the needs of individual infants at their current level of stability and need. So Henry's observation led to recommendations for considerations for pacing, pausing, and gentle support around his feeding. These suggestions were offered for the family and healthcare professionals to support the development of their ongoing care plan. Using behavior as a guide to support interactions and care requires attunement and education. This is an example of caregiving based on NIDCAP understandings. So in the first image, the caregiver is seeing the infant that they're caring for in distress, with flaccid extended arms, legs, and trunk along the mattress, pale and mottled, and interrupted sleep. This observation guided the caregiver to gently move the baby into side lying, place a blanket over him, and offer calm, steady hand swaddling containments for his shoulders, arms, and head. The result in the third image is that the baby relaxes, his tone returned with tucked, flexed postures, his hands were by his mouth for self-soothing, and likely steadier breathing and stable color. The caregiver skillfully provided the support needed for the baby to then support himself. Babies continuously interact with their surroundings, adjusting their behaviors based on the feedback they receive. So just as the environment may be very costly for the baby, with flat mattresses and no human connection, Providing covering, supportive positioning, and human containment and connection positively rebalances and steadies the baby, enhancing stability, regulation, and relaxation. Since brain development unfolds with the inputs it receives from the environment, NIDCAP care offers protections for the developing brain. NIDCAP is brain care. In the first image, we can imagine that the baby's brain is wiring itself differently than it would have in the womb, and also differently from the experience in the second image. Continuous moments of stress are likely contributors to the less favorable short and long-term medical neurodevelopmental outcomes. So the second image of this baby shows a moment that more closely approaches womb-like containment support, and positive experiences foster more positive experiences, which ultimately lead to healthier outcomes. Heidi stated, babies look for peaceful and assuring intimacy, no matter if a central line or procedures are needed. Peacefulness, intimacy, and all other aspects of nurturance, including understanding of the baby and the baby's needs, are most naturally and effectively provided by the infant's parents. No bed or material can replace the significant benefits of the parent's presence and their body and chest. While many NICU professionals play critical roles for the survival and care of infants, the unique investment and relationship that parents have with their babies is essential for healthy development. So the NICU approach recognizes that every part of the care experience matters. NIDCAP emphasizes individual care for each baby, including considerations for support for restful sleep, relaxation and wakefulness, timing and pacing of caregiving, support of holding and positioning, tucking, grasping, and bracing containment, creating calm environments with low lighting and muted soft sounds. So many of those considerations that I've just described are being applied in these examples. So this first one shows couplet care, where mothers and newborns are cared for together from birth. And the second one, a mother comforting her infant during what could be a difficult eye exam without this support. So parents' presence provides invaluable nurturance and care. By creatively evolving our ICU practices based on insights gained from individual infants and families, we can enhance our immediate care as well as shape the future of NICUs and other infant ICUs. From admission to discharge and home, throughout the day and night, parents play an integral role in co-regulating and nurturing their babies from sleep to before, during, and after procedures and other NICU care. Parents are increasingly encouraged and supported to become active, integral members of the care team, including taking the lead in developing care plans. Parents' interactions with their babies are so very important. For each small moment of nurturance provides scaffolding for healthy development and relationships by strengthening abilities, strivings, health, well-being, and resilience. Parents are the constants in their babies' lives even before birth, and they're their baby's lifelong supporters and advocates. And in this unexpected and medically complex hospital setting, parents require support themselves to assume the role of caring for their preterm or medically ill infant. Last year, our NIDCAP group proudly partnered with the NICU Parent Network's initiative in the development of the position paper on continuous uninterrupted family presence in the NICU from admission to discharge. And this statement advocates for parents as their baby's primary caregivers and recognizes them as essential, equal, and integral members of the care team. So this principle lies at the core of NIDCAP's framework. NIDCAP is described as compassionate care and nice for babies and families. And NIDCAP is those things, and it's so much more. Research evidence suggests that it has significant positive impacts on medical and neurodevelopmental outcome. This slide lists a summary of the findings from 15 studies. 10 of them were random control investigations. For the very early born preterm infants, there were numerous medical benefits with significant reduction of days on the ventilator and receiving oxygen, less severity of BPD and incidence of IVH, fewer weight gain and growth issues, and shorter length of hospital stay, and younger age of discharge. When these very early preterm infants and preterms born older than 29 weeks were combined, there was shown to be significant improvement in neurobehavioral functioning, EEG and MRI findings, and in parental confidence and competence. Heidi wrote, "It is up to us to safeguard a quiet, soothing environment for the infant and the family. Only then will security and trust grow." So it is up to us, families and family advocates, healthcare professionals and staff, hospital administrators. Everyone has a critical role to play to improve experiences and outcomes. The NIDCAP perspective supports NICU professionals to embed a developmental perspective into their expert medical and nursing care, working with and through the parents. This involves individualizing care, flexibility, and a willingness to adapt, all grounded in nurturance and relationships. So to achieve this, professional caregivers must be reflective in their practice, and they require their own nurturing, education, guidance, and leadership for effective implementation. Nurturance is significantly influenced by the environment of the hospital and its units. The goal to ensure that the dignity, comfort, and well-being of infants, families, and staff are highly valued. So every aspect of the hospital setting reflects this commitment to nurturance for infants, families, and healthcare settings, and healthcare professionals and staff. I just looked over at the time, sorry, I got distracted. This includes the pathway and design of infants and their infant family care areas and professional areas, the sounds and lighting, the availability and comfort of furniture, the nature of signage, location and storage of used and unused equipment, art and decorations, as well as the policies and the spaces that welcome families to be together with their families 24/7 in the infant care family care room. So most importantly, it considers whether the infant feels home-like or clinical. Collectively, these elements contribute to the overall atmosphere of the unit and influence the tone and the possibilities for care. Everything matters, from the philosophy and care for infants and families and healthcare professionals to the physical environment itself. Every policy and practice ultimately impacts the experiences of babies and families, which in turn affect outcomes. To support the integration of NIDCAP throughout all areas of hospitals, especially infant ICUs, the NIDCAP nursery program was developed. The NIDCAP nursery program is a valuable resource that facilitates the transition to providing highly attuned NIDCAP care. At one end of the infant ICU care continuum are conventional ICUs, and these nurseries are often loud, bright, cold, and hectic. Infants are frequently isolated, while parents are viewed as visitors. Medical nursing care are typically delivered as routines, procedures, protocols, and schedules imposed on the baby. This was the experience that Mandy described in her NICU journey with Amelia. At the other end of the continuum is highly attuned NIDCAP care. Care is individualized, developmentally attuned within expert medical and nursing care. Infants and families are supported to be together from birth throughout the hospitalization. Parents are considered their baby's primary caregivers and are key members of the medical care team. Healthcare professionals support infants, families, and their colleagues, as well as are supported themselves. And the hospital and unit are welcoming, nurturing, and home-like. The NIDCAP nursery is both a goal and a guide. Every NICU and ICU setting for infants and families falls somewhere on the continuum from conventional to the goal of highly attuned NIDCAP care. To support to support hospitals to increasingly integrate NIDCAP care, the NIDCAP nursery model offers a guide, resources, and support. So key steps in this transformation include forming a multidisciplinary team that incorporates parents, conducting self-assessment of the unit's strengths and areas for growth, setting and planning goals, and implementing developmental care education, training, mentorship, and reflective practices to facilitate ongoing change. NIDCAP is best delivered when there is the dynamic full integration of expert medical and nursing care securely embedded within the mission and active pursuit of mutual respect, caring, nurturance of, and collaboration with infants and families, and among professionals and staff members. Nurseries and units from around the world who provide this exemplary level of care may receive NIDCAP nursery certification. This NICU from Copenhagen has been recognized for highly attuned NIDCAP care that they provide in their unit, for the philosophy and care of infants, families, and healthcare professionals and staff, and for the environment itself. This is a model and an inspiration for all. NIDCAP's model, training, and certification programs and membership community are supported by our nonprofit organization, the NIDCAP Federation International, or NFI, with our mission to improve the future for all infants in hospitals and their families with NIDCAP care. The NFI partners with organizations that share similar missions, and we're proud that the Family Centered Care Task Force is one of them. We have 32 NIDCAP training centers around the world that are from 6 continents, and they provide NIDCAP training and mentorship. To date, we've certified over 3,000 NIDCAP professionals. On March 20th each year, during World NIDCAP Day, the NFI honors preterm and medically at-risk infants and their families and healthcare professionals who care for them, as well as our global NIDCAP community, and we welcome you to join us. I wanted to share with you a new resource that I wrote for parents with newborns and infants in the ICU called Being With You Is Everything. And this little book with the big message was inspired and based on NIDCAP and is written in the voice of the baby with reassuring messages for parents and in the nurturing care of their baby. The second half of this book includes a blank journal pages for families to reflect on their own experience and their unfolding relationship. So bringing this back to where we began, every family with new babies experience their own unique journeys. Here is another family with an unexpected early birth, yet with a hospitalization that was supported by NIDCAP care. These parents are from Sweden, and they had a son who was born prematurely. They experienced a NICU that integrates NIDCAP into its policies and practices. Magdalena and Andre described their NICU experience for our NFI Developmental Observer publication, and they wrote, "To be able to carry a child is a gift. Giving birth in Sweden is a privilege. To be cared for according to NIDCAP is beyond everything." So the following is going to be some of their experiences as part of a study where they were supported to hold their infant skin to skin from birth. We were both convinced that our little boy needed us 24/7 and divided the day into 8-hour shifts to be able to give the best care for him. We took turns having our little one on our chest, skin to skin. The days went by, 7 days passed before Benjamin was put in his bed. With a firm and secure hand from the healthcare team, we were guided through newborn care and our premature parenthood. Magdalena goes on to say, "We learned how important it is to speak in a lowered voice, how to provide positive touch and not to stroke Benjamin on his skin, how to protect him against bright light, how to support him with soft hands, arms, and our bodies, how to wash him, care for him, and when the time came, how to arrange his bed for best support." All this was given to us, allowing time for us to adjust and become comfortable caring for Benjamin. We got the best for our son, and with that, we were shaped into secure, calm parents who could focus on providing love and care for our son. So the nurturance provided to this family by the NICU healthcare team created a supportive environment for these parents to get to know their baby and themselves as his parents, and for all to thrive. So the NIDCAP model, as seen in this graphic, describes the nurturing and being nurtured caregiving approach with skillful medical and nursing care embedded within sensitive attunements with infants, families, and for one another. So the confidence, competence, and joyfulness that Magdalena and Andre described parenting Benjamin during their NICU experience are what all families deserve, especially ones with preterm or medically ill infants. Mandy's heartbreaking experience underscored our responsibility to realign the relationships between the mother-infant, father-infant, and the whole family as they transition from the womb and pregnancy to the infant held within the parent's arms, hands, and bodies, from admission to discharge and beyond. So learning to listen and support each newborn and infant and each family and to one another improves futures for all. So thank you. To learn more about NIDCAP, we invite you to visit our website for information and resources. So thank you.
Thank you so much, Deborah, for that. I was going to share a bit about my experience with just a primary nurse who is NIDCAP trained, but really I don't have anything to add to what you showed throughout your presentation on the importance of the nurturance of of the family and the baby, like I said, our daughter Zoe was in the NICU for a very long time and had a primary nurse for about 3/4 of the time she was there. I didn't know she was NIDCAP trained until I heard Gretchen Lawhon give a talk about NIDCAP back in, gosh, I think it was 10 years ago. And I texted her, I texted Zoe's primary nurse and I said, have you heard of NIDCAP? It sounds just like, like what you did for me. And she said, I'm NIDCAP trained. And I was like, okay, well, that makes sense then. But it was particularly for Zoe, who it took a very long time for me to feel a connection with her because couldn't hold her till she was 2 months old. She was very sick for a very long time. Lots more tubes and wires than Avery or Lily ever had. And but once she was in that private room with Susan as her primary nurse, they were 1-to-1. Everything changed. Even with all of the tubes and all of the wires, Susan was able to coach and mentor and support us in learning how to connect with her and to read her cues and to begin to develop that bond with her. And I know over those months, it's what helped us feel confident to bring a baby home with a G tube and oxygen and hearing aids and everything else. So thank you for the work that you do. We do have some questions that I want to go ahead and ask you. One is, you mentioned how many NIDCAP trained professionals there are. How long is the training? And how do you get the training?
So on our website, there is a page that describes where our training centers are located. So there's a handful of ones here in the United States, and then many, many beyond. So I think one first step would be to kind of look at that and maybe reach out to the training centers that are near where the people are located who have those questions. The training process itself depends a lot on the experience and availability to do the training. So it's typically 1 year to 2 years to become a NIDCAP professional. And then there's steps beyond that of further training, but that's kind of the beginning place to start.
And can you talk a little bit about some of the barriers to implementing NIDCAP, I would say particularly in the US?
Particularly
that's a loaded question.
Yeah, that's a big question. It's a model that's all about going with strengths and having people feel valued and respected. And so I think in each hospital, each unit has its own people and story and history. And so with each time that if people are looking to integrate NIDCAP into their unit, it's the first place to start is by looking at what's already happening. And there's developmental care aspects happening in nurseries, even if it's not NIDCAP care per se. Many people are these ideas have been kind of growing for a long time. So there are aspects of developmental care happening. So it's kind of looking at what's happening in nurseries and where can we kind of grow our program. And so developing a multidisciplinary team that includes the parent voice to kind of look at where are we right now and where do we want to grow our program is I think rather than looking at it as barriers, I would look at it as opportunities. I would think about where is it going well and where can we grow that. So I don't know that I answered that question, and I don't know if I have Fatima and Jennifer. I have some of my NIDCAP team here.
I know
So
you've
I don't know
got some of them here.
they would like to jump.
Feel free to unmute if you want to offer anything. We have just another minute. Could you talk a little, just for one more minute, about the parental education component to NIDCAP? Because I know that that's something that has been a key priority, is kind of is the parental aspect
Mhm. So the parental voice, so our tagline for our group is the voice of the newborn, but really it's the voice of the newborn, the infant, and the family. And I think the family's voice really informs, and the baby obviously, informs the work that we do. And we have worked to create support materials for families and are in the process of creating more. Our training program is geared towards training healthcare professionals to provide kind of NIDCAP care programs to support families to be with their babies. So we are not training parents to be NIDCAP professionals. We're supporting parents to parent their children. And I think when we talk about, like, parents can learn how to give a bath and how to do a diaper change and how to take temperatures. We don't teach parents how to parent. We just create the space for parents and babies to be with one another, to learn about one another, and for the relationship to unfold. So our training program is really designed for healthcare professionals, although there are family advocates who have certainly gone through the training program, but it's not designed for families to learn. One of the things I talked about in my talk was that parents get really good at learning the medical language of the nursery. NIDCAP has its own medical language, not medical, but we have a vocabulary for behaviors that we see, but it's not our parents don't need to learn a vocabulary to get to know their baby, if I'm describing that well. So our goal is to support families, and so to create nurseries that provide this care.
Thank you, Deborah. Malathi or Morgan or
Yeah, it's looking like we've reached, unfortunately, I feel like we could be here all afternoon talking about NIDCAP and the Butterfly Project. Thank you so much to our fabulous speakers today. We look forward to our next free educational webinar, which is taking place January 8th of 2026. Thank you all so much for taking the time out of your day to join us, and we look forward to seeing you in a couple of months.
Thank you, everyone. Bye.
Thank you.